Right. Well, I think we will go ahead and get started. So thank you everyone for joining us here today. My name is Scott Pearson, and I'll be moderating today's webinar on behalf of the Ambulatory Care PRN Education Committee. And we're also excited to be partnering with the Geriatric PRN for this fall webinar. And we have two excellent speakers with us today who are going to be sharing their expertise related to considerations for older adults within the ambulatory care setting. So our two speakers for today are Dr. Adenika Tanda Oshakoya and Dr. Insaf Mohammed. Now, if you have questions for our speakers at any point throughout the presentation, please feel free to type those into the chat, and we'll have some time set aside at the end to address those questions. Our first presentation by Dr. Atanda is titled Better with Age, Updated Guideline Criteria for Potentially Inappropriate Prescribing in Older Adults. Dr. Adenika Atanda Oshakoya is a clinical associate professor at the University of North Texas System College of Pharmacy, or UNT-SCP. Since joining the college in 2016, she has served as the director for the UNT-SCP/HSC Health PGY2 Ambulatory Care Pharmacy Residency Program, director for the HSC Health Diabetes Self-Management Education and Support Program, and director of the Introductory Pharmacy Practice Experiences, as well as Assistant Dean of Pharmacy Student Success and Academic Performance. As a board-certified ambulatory care specialist and certified diabetes care education specialist with 10 years of clinical practice experience, she's provided pharmacotherapy management services in the geriatric care practice setting over the past 8 years, and has participated in numerous interdisciplinary projects and presentations related to geriatric care topics. Please welcome Dr. Atanda.
Thank you very much, Scott, for that presentation, and thank you all for joining me this morning or afternoon, depending on where you are. I'm excited to be talking to you all today about the updated guidelines for potentially inappropriate prescribing in older adults. To get us started, there are no disclosures to make in terms of financial relationships. And these are the learning objectives that will be covered. So we'll be talking about the impact of polypharmacy and inappropriate medication prescribing in older adults, specifically within the United States. We'll also be comparing and contrasting two of our kind of relevant criteria for prescribing in the older adults, and that is the Beers criteria by the American Geriatrics Society and the Start-Stop criteria as well. So to get us started, in looking at the NHANES survey among our older adults of 65 years of age and older in the United States between 1999 and 2020, we did notice an increase in medication use from 83.9% to about 90%. And most of the medications that were in that particular category were cardiovascular, gastrointestinal, metabolic, and psychotherapeutic agents, which are common medications that we see in practice. Also important to note that there was an increase in polypharmacy from about 23.6% to about 43%. And we define polypharmacy as the use of 5 medications or more. There was also an increase in hyperpolypharmacy, which is defined as 10 medications or more in a medication regimen, and that increased from 1.8% to about 6.1%. And looking at the CDC kind of health statistics report from 21 to 22, we also were able to see about, again, 88.6% of older adults were taking medication, prescription medication in the last 12 months, and that we did have mostly private insurance coverage for our medication use in that particular population. So what is polypharmacy and why are we seeing an increase in polypharmacy over the last decade or so? The most common consensus in terms of definition is that polypharmacy is a medication regimen of 5 medications or more. But there are also additional kind of definitions that indicate polypharmacy is the use of more medications than is clinically indicated in a patient's regimen. Polypharmacy can be concerning, especially in the geriatric setting, because of an increased risk of medication non-adherence, medication adverse effects or events based on, of course, of drug interactions and other problems, increased risk of hospitalizations due to, again, side effects or overdoses, and then an increased risk of disability, cognitive decline, and mortality in that particular population. So what are some of the causes of polypharmacy? The most common cause, again, in the older adult population is just an increase of multimorbidity. And so multiple kind of comorbidities and complex drug regimens to manage these different comorbidities. We also can see, unfortunately, an increased risk in medication adverse events and prescribers actually prescribing medications to manage those side effects as a result. Also, an increased risk of hospitalizations in this population can lead to an increase in medication prescribing and sometimes a decrease in deprescribing that is appropriate. The use of multiple prescribers, especially the use of specialists, increases in this population. And unfortunately, we do not currently have a shared EHR that can promote, kind of transparency in terms of medication regimens. And so sometimes we have patients having duplicate therapy or inappropriate medication use due to just multiple prescribers and the use of multiple pharmacies that prevent the kind of centralized review of all of their medications by healthcare providers. So when we think about polypharmacy and its effects in the older population, we also have to be concerned about these potentially inappropriate medications and how we identify them and manage them in this population. And so based on the Beers criteria, potentially inappropriate medications are defined as medications that are prescribed without an indication or medications that the net clinical kind of risk outweighs the benefits. This is different from inappropriate prescribing, which is defined as medication use outside of the bounds of acceptable medical standards. Most times, these medications are used within approved indications, but because of the unique kind of qualities and variables within geriatric care, they become inappropriate for some of our patients, and we need to be mindful of that. And so currently, there are two main guidelines that help us navigate the decision making as it relates to the geriatric population and medication use. The first one is the American Geriatric Society Beers criteria, which is most commonly used in the United States. And then we also have the STOP criteria, which is the half part of the STOP START criteria that also helps us identify these potentially inappropriate medications. So I would like to spend some time now talking about the Beers criteria and how you can use it as a clinician in your particular practice. And so this criteria was developed by Dr. Mark Beers in 1999 with his colleagues, but was transitioned to the American Geriatric Society in 2011.
This meeting is being recorded.
And this particular criteria also lists different medications based on 5 categories. The first category is those that are potentially inappropriate just based on the older adult population. Second category are going to be those that are inappropriate based on certain in caution or used to use with caution. And then medications that have potential drug-drug interactions. And lastly, medications that have either dose adjustments or contraindications based on renal function. So based on the Beers criteria and how they've grouped medications, these are the more common medications that we're going to see highlighted as high-risk medications in the older adults. And these are medications, again, that we commonly see in practice from anti-infectives all the way to antithrombotics. Last year in May, the Beers criteria was updated, and there were some significant changes made compared to the 2019, which was the previous edition of the Beers criteria. And so one of the updates includes updating the actual list of the PIMs, which are the potentially inappropriate medications. And they looked at the evidence that was available between 2019 to 2023 to make the updated decisions. The 2023 guidelines also provide some additional recommendations based on anticoagulation, and there's a separate table that highlights what the recommendations are and the evidence behind that. We also have some changes in terms of removal of medications that were previously in the 2019 guidelines based on emerging evidence as used to more streamline the list of medications for us to consider. And so I wanted to spend some time talking about some notable changes in the Beers criteria in terms of our 2023 update. And so the first column is going to be medications that were removed from the Beers criteria. And so the first one is going to be apixaban, and this was removed from the criteria, especially when it came to creatinine clearance and renal function, because we now have evidence supporting safer use at lower renal function. And so we can safely use for most patients apixaban in terms of our VT management and also non-valvular AFib or atrial fibrillation management in patients that have end-stage renal disease and also are on dialysis. Another removal from the Beers criteria was meperidine. This was not necessarily removed, but actually just subsumed under the opioid category, as we now have a general opioid warning for concerns in delirium in the older adults. There were several medications that were either not on the market anymore or had low use, and they were also removed from the particular Beers criteria based on the update. One notable one is going to be ranitidine, where we had that massive recall in 2020 due to having NDMA, which we know is a carcinogenic contaminant that was found in that particular product, and so it's no longer on the market, and as a result was removed from the Beers criteria. Some notable additions to the criteria last year were in an anticoagulation category. And so we now have a warning to avoid warfarin and rivaroxaban as initial therapy in non-valvular atrial fibrillation and VTE management based on new data. And this data really stems from an increased risk of bleeding and GI bleeding seen in kind of studies and surveys in comparison to apixaban. And so, of course, this does not mean that we can never use warfarin or never use rivaroxaban. It's just that the AGS is encouraging apixaban to be the preferred agent of choice, unless, of course, you have concerns for cost and or a patient who prefers once-a-day therapy. For dabigatran, we still have use with caution based on GI bleeding risk profile, and that has remained the same. We also have this new category here on opioid use and delirium. Of course, we do have appropriate reasons to use opioid therapy in the older adults, but we do need to be mindful of the risk tied to delirium and how we can either monitor for that or use a multimodal approach to reduce our overall opioid consumption and use in our older adults. Medications like dextromethorphan which is typically used for pseudobulbar affect to manage that condition, has been actually shown to have concerns in heart failure population and patients who have QTs that are prolonged. And so there have been an addition now based on the package insert to avoid this particular medication in patients who have heart failure. Some important drug-drug interactions to highlight include muscle relaxants being used with more CNS active agents and being mindful of the impact on that on overall CNS depression risk. We also have an addition there for lithium with medications like ACE inhibitors, ARBs, and ARNIs to avoid an increase in lithium levels that can lead to toxicity when the combination is on board. If patients have to be on both medications, it's important for you to have appropriate monitoring in place to ensure that levels, again, if they go above 1.5, can be appropriately addressed and lithium dosing adjusted. Medications like warfarin and SSRIs also have a drug interaction, and this can increase the risk of bleeding due to, again, an impairment in platelet aggregation in that particular drug interaction. There was also an addition for ticagrelor and prasugrel to be used in caution in patients in older adult population due to an increased risk of bleeding when compared to clopidogrel. And then lastly, baclofen should be avoided in patients with a creatinine clearance less than 60 due to an increased risk of encephalopathy that was noticed in post-marketing studies. So if you were to pull up a PS criteria, here's an example of what it will look like. And so again, we typically will have the different categories. This category is looking at drug and disease state kind of interactions that need to be mindful of in the older population. And so here you see the particular disease state, you see the drug, and then the rationale provided for this particular recommendation. The good part about the Beers criteria is that it also provides the quality of evidence. And so it'll tell you again, depending on the quality rating, if it's something that has stronger quality for more of our randomized controlled trials, meta-analysis, or if it's a lower level of evidence, and also the strength of recommendation from, again, lower to strong recommendation strength. So now I want to switch gears and talk about the stop-start criteria, and again, compare that to the Beers criteria, but also highlight some things that are a little different. And so the stop-start criteria was actually created by Dr. O'Mahony in 2010 and is typically seen and used in European countries. This particular criteria is a little unique in that it has two parts. The first part is the START criteria that actually lists those potentially inappropriate medications, but we also have the START criteria, which is a list of medications that should be considered to be started in older adults for different indications. And so we have 133 STOP criteria and then 57 for the START criteria. So in comparing our 2019 version of this to the 2023, there were several changes made in different physiological kind of categories, with majority of the changes made in the cardiovascular, coagulation, and CNS categories. And so for the sake of time, I wanted to just kind of show what an example of that would look like. And so for the STOP criteria here, you can see in this particular version that we have the cardiovascular system being highlighted. And then there's a list of medications to either avoid or be cautious in terms of use in that particular older adult population based on the disease states in the cardiovascular system. And then comparing that to the START criteria, this has a similar setup in looking at the cardiovascular system, but it will actually list the medications that should be started based on different indications and needs within the older adult population. In comparing this to the Beers criteria, again, we don't typically have a list of evidence in terms of the quality of the evidence and the strength of the recommendation. But again, it does provide you at least recommendations in the STOP criteria and then things to consider adding in the START criteria. So in comparing both, again, we typically will see more of the Beers criteria here in the United States because this is where it was originated versus the stop-start criteria that we typically see in European countries. It's important to keep in mind that, again, some of the recommendations might differ based on what's been approved by the FDA and other governing bodies. And so it's important to read the full length of the recommendation when considering that for your patient's care. The Beers criteria does a great job identifying PIMS, but the stop-start criteria also identifies prescribing omissions that needs to be, again, considered in our older adults. Both of the criteria are kind of different in how they group the recommendations. The Beers criteria typically will group it based on drug categories or classes, while the stop-start criteria has it based on physiological systems. And so be mindful of that while you're looking for a particular medication. It's going to be categorized differently depending on the criteria you used. And then lastly, the Beers criteria does provide in each recommendation the quality of the evidence and also the strength of the recommendation for you to consider. Now, this is, again, a guideline for you to use. This is not to replace clinical judgment, and both criteria are not typically to be used in our kind of end-of-life care setting, so hospice and palliative. They're not appropriate for use in that particular care setting because the treatment goals are different for those patients. And so these are typically to be used for our patients who are ambulatory or in an institution like a hospital or a nursing facility. So to kind of summarize our talking points, I wanted to highlight some things that you can do as a clinician to really encourage appropriate medication use in older adults and to discourage inappropriate prescribing in your practice. The first thing to consider again is the kind of utilization and the benefit of medication reconciliation. So this should be done at every visit, and your patient should be provided an updated list for them to have, and so they can share that with other specialists and also their pharmacists if they're going to use multiple pharmacies. It's also very important to do this, especially when it's a new patient or they're transitioning between care settings to avoid, again, those errors and duplications that can occur when they're transitioning between settings. Also consider using prescribing criteria like the BS criteria or the stop-start criteria when you are reviewing medication lists to ensure that the medications are appropriate and to encourage deprescribing if needed in this particular population. I also like to encourage, patients and providers to have their patients use one pharmacy. That way that at the dispensing end, we can catch errors, especially as it relates to duplication, drug interaction, and inappropriate dosing as well. And then lastly, consider using your prescription monitoring programs when you are looking at medication lists to ensure appropriate use of controlled substances and controlled medications, especially in the older adults, to ensure that there is safe use and that we can catch any inappropriate behavior in terms of our patients' use of controlled substances. And with that, I would like to thank you for your time and pass the presentation to Dr. Mohammed to talk about opioid management considerations for older adults.
Great. Thank you very much, Dr. Atanda. And so as a reminder, at the end of these presentations, we will have a Q&A period. So we'll hold questions for now, but please feel free to enter any of those into the chat at any point as you have them, and we'll be sure to have the speakers address those at the end of the presentations. But for now, we will move on to Dr. Mohammed's presentation titled Opioid Management Considerations for the Older Adult. Dr. Insaf Mohammed has been a clinical assistant professor at the Wayne State University Eugene Applebaum College of Pharmacy and Health Sciences in Detroit, Michigan since 2017. She has a shared clinical appointment with Corewell Health Hospital, Dearborn, where she practices as an ambulatory care pharmacist specialist in an internal medicine clinic. She also serves as the Director of Quality Improvement and Scholarship within the Corewell Schaefer Internal Medicine Residency Program. Her areas of practice and research interests include interprofessional diabetes management and controlled substance risk mitigation. She also recently completed her term as chair of the ACCP Ambulatory Care PRN. Please welcome Dr. Mohammed.
Thank you so much for your introduction, and thank you for the great presentation, Dr. Atanda. I look forward to spending a little bit of time chatting with you all about opioid management considerations for the older adult. I have no conflicts of interest to disclose at this time. And in terms of what we'll be covering during this short time, we will identify opportunities to improve safety on opioids in older adults and also discuss alternative treatment for pain management and medications for opioid use disorder among older adults. So just a quick review of statistics that you're all familiar with. 30% of Americans have chronic pain versus 16% that have opioid use disorder, although we know that this is a vast underrepresentation due to the limited screening and diagnosis that we have. While we have seen prescriptions for opioids decrease over time, we still have a problem. In 2014, we had 245 million prescriptions for opioids versus 142 million in 2020. However, we still know that there are about 5% of US counties that prescribe enough opioid for every individual in that county to have an opioid. So while we see these decreases, we know there's wide variability. Furthermore, we continue to see challenges with overdose death related to opioid use. Particularly in 2017, we had over 48,000 overdoses versus over 100,000 at the end of 2021, which was the highest recorded number of overdose deaths in a 12-month period. And historically, we have seen that older adults have been perhaps not the population that was most impacted by overdose and overdose related death. However, we have seen that this has changed over time. The prevalence of chronic pain is very high among older adults, up to 85%. And we're also seeing an increase by threefold in the diagnosis of opioid use disorder among older adults, and therefore a rise in opioid overdose deaths as well has been seen. Historically, we haven't really seen much of this in the age group of 65 and older, but we are starting to see a rise among individuals who are between 55 and 64, and also seeing that rise among individuals over the age of 65. And this graphic here is just demonstrating the percentage of drug overdose deaths involving the listed agent here. And it's just showing that there is a substantial amount of deaths related to not only prescription opioids, but also synthetic opioids and heroin, which we know that our patients are often opting for if they're unable to get to a source that may prevent opioid withdrawals, for example. And just as a reminder, we know that many individuals are seeking an opioid source simply because they are trying to or prevent an opioid withdrawal, and they need that source to prevent that. And those agents that they're able to get on the street are sometimes more accessible to them than prescription agents. So let's meet Mr. T and kind of link this all to a case. So imagine you have a 73-year-old patient who's been taking morphine 30 milligrams twice daily and hydrocodone acetaminophen 7.5, 325 twice daily as needed for breakthrough pain. He takes this regimen for back pain, hip pain, and knee pain, and he's been maintained on this regimen for the past 8 years. He has a few chronic conditions, including depression, and has tried physical therapy, topical pain medications, epidural injections, and acupuncture. And he simply states that this is the regimen that helps him maintain his daily activities and take care of his disabled daughter who lives at home with him. So imagine he comes to the primary care office today and is asking for a refill on the pain medications, and one of the providers asks you for your recommendation on how to proceed with this patient. And I'm sure many of you are having some thoughts. And when we think about what the options are, we can simply refill the medications and continue them. He's been on them for 8 years. But the thought becomes, well, are we doing nothing to reduce the risks that this patient may be susceptible to? Option two is to stop the medications. Well, if we think that the medications have safety concerns, perhaps we should simply discontinue them. However, we know that there are risks associated with discontinuation, particularly with risks of complex persistent dependence, issues with patients potentially being lost to follow-up and deciding to seek care elsewhere, and even some literature demonstrating that perhaps patients will have declining mental health management and even suicides when we abruptly discontinue opioid therapy? Or do we do something else? And what is that something else? And perhaps why we are most concerned about this patient that I presented is because we know that older adults are at an increased risk for opioid related harm. And that's due to the adverse effects, that's due to the cognitive impairment that can be present in any patient, but amplified in the older adult, altered drug metabolism related to renal and hepatic function decline over time, falls and fractures, polypharmacy, and there's even literature demonstrating that older adults heightened risk for all-cause mortality when they are maintained on opioids over time, and these risks exist even at recommended doses and durations of opioids. So, what can we do and what are the options if simply continuing the medication present challenges, and if simply discontinuing the medications present challenges? What can we do? And that's where risk mitigation strategies come into play. And these include assessing the individuals who may be at the highest risk so we can prioritize who are these individuals who perhaps we need to intervene on, who may be at the highest risk of overdose and overdose related death. We need to consider alternative treatments and medications for opioid use disorder, which is where we will be devoting most of our time today during this presentation. We need to reduce risky combinations, and particularly the highest risk combinations are opioids with benzodiazepines, as well as the hypnotic sleeping agents. We also need to conduct urine drug, use it as a therapeutic tool, not as a punitive tool, such that we can potentially identify agents that may increase risk of harm that perhaps are not prescribed, or perhaps that patients may not be aware of in terms of increasing their risk, or as an opportunity for us to intervene and refer our patients for substance use disorder management if we identify things in the urine that require intervention. Co-prescribing naloxone is perhaps the easiest thing that we can all do as pharmacists in any care setting, such that it can be on hand for an emergency situation in which an overdose occurs. Controlled substance agreements are documents that can be used between prescribers and the patient to establish the responsibilities of both parties and to ensure that monitoring and safety parameters are in place at all times. Prescription drug monitoring programs, as well as effective communication to educate on the risks of opioids and discuss alternative treatments. So these are all strategies that exist for us to use with our patients. The dilemma in older adults is that we know they have an increased risk of pain, and we want to prevent the negative consequences of untreated pain. However, we know that there are challenges with non-opioid analgesics that prevent us from using some of these agents that we perhaps consider more safe than opioids. So there was a recent review of evidence-based pain management in older adults that was published by the British Journal of Pain in 2022. And what they found was really nothing groundbreaking. However, they found that the evidence suggests that management of pain in the older adults should be centered on topical medications, which are safer than oral options when we're able to use those topical agents, using rapid acting agents instead of extended release agents, starting at low doses and going slow, using combination therapies with different mechanism of actions when we're able to, and opting for non-pharmacologic options, again, when that is accessible and available to our patient. So nothing here that is necessarily new information to us. What they did do is they went into some of those non-opioid agents and discussed the literature surrounding their use in older adults. And what we have found, and the theme that you'll probably see throughout the remainder of this presentation, is that there is very limited research that is high quality among older adults when it comes to the use of pharmacologic agents for pain. And for instance, there was some evidence that was presented on acetaminophen that has found that really we have very limited evidence on long-term use of acetaminophen in the older adult. And we have even found some systematic reviews and other studies that have identified risk of certain adverse effects, such as cardiovascular disease, renal disease, GI adverse effects, when in older adults are continued on acetaminophen long-term. So the recommendation from this particular publication and this review was to consider acetaminophen for short-term treatment, but be cautious when it comes to long-term use because of our limited understanding on the safety concerns. NSAIDs are to be avoided for chronic pain in older adults due to the adverse effects that we're widely aware of, including cardiovascular, renal, and GI side effects, and to use our evaluation of the risk versus benefit to use it for the lowest dose and the shortest duration when we need to. Opioids, the recommendation was to avoid use for chronic pain due to the risks in older adults, and really the lack of evidence in any population for the benefit of chronic pain or chronic non-cancer pain, at least. In terms of adjuvant drugs such as antiepileptics and antidepressants, caution is also advised in this review for older adults due to the side effects that exist. However, they can be used but introduced gradually and monitored carefully over time, with particular caution for drug-drug interactions that exist with these agents. And lastly, they do suggest that topical therapies are completely fine and available to be used and preferred to be used. However, we do know that there are some access issues, insurance coverage issues, and there may be certain patients in which this works and others in which topical options perhaps may not be effective. So being mindful of that is key. So the question is, what can we do when there are so many limitations? If we can't use opioids, and we're finding that the highest quality literature that currently exists tells us that even things like acetaminophen are potentially not safe over time, the question is, how do we proceed with managing pain in the older adults? At least that's the question that I'm left with. And I think ultimately what the guidance suggests is that we just need to simply consider the risks versus benefits as we do for any patient case, being mindful of the case of the fact that perhaps acetaminophen is safe. Perhaps these other agents are okay to use with appropriate monitoring without just simply assuming that they are safe over time in these patients who are more susceptible to long-term side effects and risks. So many individuals will ask, well, what about tramadol? And we know that tramadol is a weak opioid and often deemed anecdotally safer than opioids. However, the Choosing Wisely initiative in June of 2022 stated, don't prescribe tramadol for older adults without due consideration for the potential risks and harms related to serotonergic access, seizures, falls, and drug interaction. And this was based on some literature that had found that the older adults account for 33% of tramadol-associated emergency department visits and 50% of subsequent hospitalization. And therefore, this study was looking at tramadol users versus non-users. And so these risks were present in the tramadol users versus the non-users. Overall, the risks for older adults who are taking tramadol were lower than the risks in older adults taking other opioids. Nevertheless, we need to be mindful of the risks that are in comparison to someone not using tramadol, and recognizing that risks simply do exist in the older adult, and we cannot deem tramadol as a safer option without due consideration for these other concerns. So imagine that Mr. T comes back and says, well, what about marijuana? He says that he heard from a few of his friends that they started using marijuana, and they tell him it's been a game changer for their pain. And he asks you, as the ambulatory pharmacist, what you think. So, just a brief review, we know that cannabis contains two major active ingredients. We have THC, we have CBD. Both of them have efficacy for pain. THC causes euphoria, while CBD does not. The pharmacokinetics do vary based on the administration and the formulation, and it is designated as a Schedule II controlled substance federally. When we take a look at the general evidence for marijuana use in pain, this is in the general population, not just in older adults. A systematic review of 28 studies has found that there is some benefit for chronic pain, including neuropathic, cancer, and fibromyalgia, primarily looking at THC products. 8 studies reported reduced pain of at least 30% compared to placebo, although there were some limitations with the findings here. And the most common side effects were dizziness, dry mouth, and nausea. Now, specifically, when we look at the research for marijuana in older adults, we do have a lot of literature suggesting that the use is increasing in older adults for chronic pain. However, if we look at the high quality literature that exists, there are simply a small number of older adults in these large studies looking at marijuana for chronic pain. It has not been analyzed for safety and efficacy in this population, and therefore we are kind of left grappling, well, is it truly safe in this population, considering the safety concerns we already know about in the general population? And then lastly, transitioning to buprenorphine, imagine that Mr. T's PCP asks you for your recommendation on buprenorphine for Mr. T. And just a brief review of opioid use disorder being the problematic pattern of opioid use leading to impairment or distress with 2 or more of the following within a 12-month period. And such a criteria of taking opioids in larger amounts or over longer periods than intended, a persistent desire, unsuccessful effort to cut down on opioid use, so on and so forth, to then be able to classify a patient as having mild, moderate, or severe opioid use disorder. When we take a look at the different agents that exist for opioid use disorder, we have methadone, we have buprenorphine, and we have naltrexone. Buprenorphine has become particularly attractive because of the removal of the DEA-X waiver requirement, such that it can now be prescribed by a primary care provider, a bit more easier with reduced restrictions, and dispensed by a pharmacy. These agents reduce illicit opioid use, retain patients in treatment, reduce of opioid overdose death better than placebo, yet we know that over 70% of patients with opioid use disorder are not on a medication for opioid use disorder. When we look specifically at older adults, again, little research in this population. There are no randomized controlled trials in this population, and we use the recommendations based on data from younger adults. We see that there is a preference for buprenorphine over methadone in the older adult due to a better safety profile and due to the enhanced accessibility over methadone, which requires a treatment in an opioid treatment program. We also know that buprenorphine can be used not only for opioid use disorder, but also for individuals who have chronic pain without opioid use disorder. And this is particularly beneficial due to the ceiling effect of buprenorphine, such that we reduce that risk of respiratory depression that we see with full opioid agonists. So the benefits in general of buprenorphine over full opioid agonist is that it has a favorable safety profile, it has a slower onset of tolerance, and it has that ceiling effect on respiratory depression, such that we should consider buprenorphine as a safer option, for example, for Mr. T or patients like him who are maintained on long-term opioids in whom we are potentially worried about the long-term consequences. And we may switch or we may think about switching when there is a lack of efficacy, when we're worried about adverse effects, when we have the concern for risk of addiction, misuse, or opioid overdose death, or when there is simply a need to utilize other formulations. So overall, older adults are more susceptible to poorly treated pain and may be at risk for opioid overdose death. Risk mitigation strategies can and should be used to improve safety on opioids and other controlled substances, and screening older adults for opioid use disorder and considering buprenorphine for patients with chronic pain with or without opioid use disorder is a consideration that we should begin being more mindful of. And with that, I think that concludes our presentation. I thank you all for being here, and I'll pass it back over to Scott to open it up for questions.
Thank you very much, Dr. Mohammed. So, as she mentioned, we now have about 15 to 20 minutes open that we really just want to hear from audience members and just have some dialogue about points related to either of these presentations. So, I don't see any questions in the chat yet, but you can feel free to enter any questions there, or if anyone also wants to come off of mute and ask a question in that manner, definitely encourage that as well. I'll maybe start with a question for Dr. Atanda. Oh, actually, I'll hold my question. I see another one in the chat here. So question is, many of person's elderly patients have experienced side effects from Belbuca doses higher than the 150 micrograms. So curious about this question for Dr. Mohammed about your experiences with these agents in the older adult.
So that is a great question, and thank you so much for dropping that. Um, I'm not sure that I have a lot of experience, particularly with doses higher than 150 micrograms in our older adults. But I guess the question becomes, are these side effects more problematic than the risks that we would anticipate from their opioid therapy? And often, by the time we have transitioned a patient to a buprenorphine agent, the question is, well, we had significant concerns while they were on that agent. So I think the question becomes like, are these side effects manageable? Have they become so bothersome that the patient cannot simply be on this agent anymore? Or is it something that we can potentially be mindful of and use adjuvant agents as well when needed? I unfortunately don't have my own experience with that, but I think those are just some of the thoughts that I would think about in that case.
Thank you. And it looks like we have another question. So this is asking, how do you approach discussing change to I think maybe mean buprenorphine in patients who might be resistant to change and have not had any side effect on their opioid?
That's a great question, Faiza. And I think that's what we grapple with a lot in clinic, because so many times patients will become defensive because perhaps they think that we're accusing them of misuse, or perhaps they are concerned that we are trying to kind of pull the rug from under them in terms of having that consistent pain management that they've had when they have particularly been managed on an agent for so long. And I think this is really where we employ discussion that we are worried about the risks over time because we know that those risks exist and we know that those risks become heightened as individuals age. And so oftentimes what we do when we have a resistant patient is we simply give the patient their time to go home, think about it, discuss it with their family, come back and answer questions. So I think the key is not mandating this switch to buprenorphine or mandating that we get you off of your opioid. I think that it can be a gradual process, and we've seen that it might take multiple visits to get a patient to a point where they're open to the idea of transition. Get some patients that perhaps are never open to that idea. And I think that's where we get a bit more creative with using our risk mitigation strategies. But often, I think the biggest thing that I've learned is being patient with our patients who simply just want their pain to be managed. And that's how I usually approach it.
Great. And it looks like we have a question now asking this maybe for Dr. Atanda. So what is the most recently updated version of the stop-start criteria?
Thank you for that. Yes, so 2023 is the most updated version of that particular criteria. And same thing for the beers, so 2023 will be the most updated version.
And question of the best way to access it.
So both of them are actually available online, and thankfully there is no, cost or fee associated with them. You can just search the stop start criteria, and usually it's like one of the first few PDFs that become available. If not, I can always share the version I have with the group, and if there's a way to, share it out to both PRNs, then we would be happy to do that as well to make it easier.
Great. And I'll share my question for Dr. Atanda now. So when you talk about Beers criteria and those combinations of medications being one of the big things that are kind of called out, I think we can all think of our patient who's on 4 or 5 of these centrally acting medications, who's older and we maybe don't feel so great about. So just curious, how do you go about approaching one of those situations when, there are a number of things when you're looking at someone's medication list that give you maybe a little bit of concern or some palpitations?
That is a great question, and that's something that as clinicians we're going to see a lot, especially in the geriatric practice. So for me, the first question I usually ask is, again, how extensive is the side effect? So if someone's having profound, dizziness, or we're now having concerns for falls and, other concerns related to CNS suppression, and then we will typically take a look at all the medications that have been flagged in terms of side effects, and then look at which ones have benefits versus the risk. And so sometimes the lower hanging fruit that we can get rid of are things like Benadryl, and trying to switch them to a safer antihistamine, or sometimes even looking at antidepressants and seeing if they're on TCA, could we switch them over to an SNRI, SSRI, depending on what their need is to mitigate some of those side effects. Sometimes we're not able to avoid all medications in that particular category, especially in our diabetes patients who are taking it sometimes for neuropathic pain. So the best approach is really to look at what is the risk versus benefit, and then trying to prioritize those medications that we know we need, and then trying to change or modify some of the lower ones that could be used for PRN disease states, or not necessarily going to affect their overall quality of life as much as the others. So it's not a perfect science, which is the caveat I usually tell our students and practitioners using this criteria. It's really just using your best judgment and trying your best to reduce that load as much as you can.
Yeah, thank you for that. And definitely it can be some challenging situations. And a lot of times patients often have strong opinions in one way or another too.
Yes, it's definitely a shared decision making. As anyone who works in AmCare knows, your patient has a lot of opinions, but also rightfully so has a lot of say in their care. And so it's really collaborating with them and making sure that you know what's actually beneficial, but also what matters to them, and trying to meet them halfway with your decision making.
Absolutely. And looks like we have an additional question here. So how do we advocate for using the Beers criteria? Feeling that a lot of providers do not always know that they exist.
Great question. So we have students within our practice, and usually they'll give like a topic discussion. So that's something to consider, doing a quick 10 to 15-minute overview over lunch and have one of your learners present. But also there is a great pocket card provided by AGS, because of course the guideline's really long and cumbersome sometimes to go through. And so the pocket card is about 16 to 17 pages. They could print it out and actually make it into a folded version. And that's something you can print out and have accessible in your break area, or again, in your practice area for clinicians to quickly review, I feel like with our providers, the more tangible and accessible resources are, the better they're going to use them. And so I found those pocket guides to be really great. And then the topic discussion really helps to increase awareness and just kind of help them navigate how to use it, how to kind of navigate the recommendations. And again, highlighting that this is not necessarily a cannot use list. It's really just highlighting things that might be more problematic in the older adults and things to be mindful of. So hopefully those strategies will make a difference.
And then quick question. Oh, yeah,
Yes, there
sorry.
is a link to the printable pocket guide. Once we're done here, I'll try to quickly find it and put it in the chat if I can. And then if not, I'll send it to to Scott and the team to share out as well.
And yeah, piggyback off of that too. I think as far as learners, if you do have medical residence students coming through the clinics too, that's going to be great resources also as far as something to have them take with them to potentially be just having more as a future resource too. See, maybe for Dr. Muhammad, I have another question, just kind of to your point about, some of these discussions about cannabis use. I think a challenging scenario sometimes that I've encountered is just patients who maybe are already on an opioid and then having questions about cannabis. And I guess just wondering, how do you navigate some of that discussion as far as, potentially combination of both, or if you're looking at more of a transition, how do you kind of approach that?
Yeah, that's a great question that I think myself in my clinic with the providers have also been kind of figuring out over time. Interestingly, if I think back to like 5 to 7 years ago, if we had a patient on an opioid who had a urine drug screen that was positive for cannabis, they were considered to have breached their controlled substance agreement and they were at risk for being dismissed from practice. And there were many patients in whom were dismissed from practice. And I think that we, not necessarily due to my decision making, but providers who simply thought that individuals who are using a cannabis product while they're also on an opioid are putting themselves at increased risk and have breached that contract. I think that we have become a bit more smarter about the kind of the risks over time. I think the overall consensus is that we simply don't have enough literature in any population to say that we can transition someone from opioids to a cannabis product. I think the risk does come into play when you have a patient who's already on an opioid and using a cannabis product. I myself like to think that we have been taught as pharmacists to be the most evidence-based practitioners that exist. And unfortunately, the evidence is just simply not high quality enough, particularly in older adults. So I generally do not recommend it for my patients. Now, if they're already on an agent, I usually don't tell them to stop it per se, but I do ask that they are making sure that they are obtaining it from a safe and validated location, that they're not just kind of like getting it from a friend or some random spot. But I've generally moved away from recommending it because it's simply not evidence-based at this time.
Yeah, I appreciate that. And to your point earlier, I mean, most of the studies that we do have for pain in particular are looking more at the THC component, which is the one that gives us a little bit more pause when it comes to other centrally acting meds and fall risk in older adults, cognition, all of that. So yeah, I think definitely an area that would be nice if we had some more evidence. But yeah, appreciate
Absolutely.
the insights. And Dr. Atanda looks like shared a link here to the Beers Pocket Card in the chat for anyone who's interested.
And I also added a link to the actual year's criteria, the full criteria as well. So you can take a look at that. For the Pocket Card, it is free for AGS members. So just keep that in mind. And there's a small fee for those who are not AGS members. There might be a PDF version online, but I'm not able to share that on here. So I have to share the official link.
Maybe I'll throw in another question for Dr. Mohammed here. So back to kind of that discussion about buprenorphine, I think another scenario that I've run into is patients just maybe they've been prescribed the buprenorphine patch or like the Belbuca, the sublingual film, but cost has sometimes been prohibitive. Um, have you had any scenarios of just, I guess, kind of navigating those situations and potentially, any evidence as far as using more of like I think the Suboxone generic version is available, but is really only approved for more opioid use disorder and just, yeah, any experiences with any of those scenarios?
Yeah, I don't really have any magic answers for the access issues because I think we run into those a lot, especially in my patient. Um, have limited insurance coverage. And so we are sometimes stuck with deciding on whether or not we'll use the agent off label, which we have in some situations. But um, in terms of access, my hope is that we start to see improved access over time. So I've had some success with things like prior authorization, but oftentimes we are just kind of stuck using the agents off label. And I think that is something that I have seen done anecdotally. We have had some success doing that as well. So I would say as long as we're not worried about the safety risks, which again, going back to the bottom line, we know that the safety is improved compared to these full opioid agonists. It is something that we have done as well in practice.
Thank you. So we maybe have time for one or two more questions if anyone else wants to, either in the chat or if anyone wants to come off of mute. Maybe I'll throw one more out there for Dr. Atanda then. Also kind of in the vein of just medication access, I think, something kind of interesting, you brought up some of those kind of recommendations related to anticoagulation. But something now that we're seeing dabigatran is actually available generically, and it seems like actually with some Medicare plans next year, cost will be significantly less than some of other agents that we have been using, like the apixaban, rivaroxaban. So just curious if you have any thoughts on that, because I think this might be a question we see coming up more is, can we switch this person to dabigatran? And yeah, just any thoughts.
Definitely. And something I try to balance in my practice as well is, of course, what's evidence-based and what's guideline-based versus what is actually affordable and doable in our patient population sometimes. It's not always a black and white decision. And so, of course, sharing the best evidence, there is an increased risk of GI bleeding typically with dabigatran compared to our other DOACs. But if it ever boils down to a patient who is not able to, afford apixaban as our preferred DOAC in this population, then it just becomes, here's the evidence. We can create some parameters around that in terms of monitoring, making sure they fully understand what to look for in terms of GI bleed risk, and how to modify that. But it's most likely going to come down to what they can afford to take versus them not taking anything at all, or sometimes struggling with warfarin as our cheapest alternative and really having a hard time getting that, INR to goal based on just lifestyle kind of decisions and choices. And so it's really case by case, but we might have to, again, come down to what's doable in this patient population, what's best for this case, and then just given some pretty robust education and support, so patients understand the risk if that was to be, switched over to a dabigatran or even a warfarin therapy at that point.
Yeah, thank you for that. And yeah, definitely, I think just scenarios that can kind of be challenging to think through and all good considerations.
Absolutely. And that's job security for us. This is why we are, very, very important in terms of our bigger healthcare team is really helping them navigate those tougher decisions and seeing what's best.
Great. Yeah, I think we are at time here, but yes, want to echo our in the chat here. Thank you very much to our two presenters for sharing their expertise and for great discussion about some of these topics. So there will be a recording of this if anyone had come on late and wasn't able to catch the whole recording. So we will have that posted to the PRN pages, I believe, with both the ambulatory care and geriatric PRNs. But again, thank you to our speakers and thank you all for attending.
Thank you.